Well, thank you very much for talking to me about the BMA's report, and I know you've got a copy of it. For me, it was really, really important to think about both physical health and mental health, and physical health and people with learning disabilities in the same report, because we know that both groups of people have much worse life expectancy than the rest of the population. And there's been a lot of work that I know that you're very familiar with on the outcomes for people with learning disabilities, and indeed the government has set up, or is in the process of setting up, a national mortality review for people with learning disabilities. It would be brilliant to know how you think that's going.
Well, it's taking longer than I'd hoped. I've spent my life feeling impatient at the slow sort of pace of things. It is, of course, important that we do it properly and that it's effective at what it aims to do. But I'm very determined that it happens. And I think NHS England are of that view as well. So I'm sort of confident it will happen, but it's just taking a longer time than I had hoped. I think they'd hoped that they would finish the procurement by next March. That appears to be now delayed. Next summer, perhaps. But you know, from my point of view, I will keep the pressure on to make sure that we get this outcome as soon as possible.
And it was one of the recommendations of our report, and very shortly afterwards, and I'm not really attributing it to our report, but it was very shortly afterwards that the government's response to the confidential inquiry agreed to set up a national mortality review. What do you think the main the hopes you have are for that inquiry, or for that review?
Well, it's to, I guess, gain understanding about, I mean, there is this really pretty scandalous gap in life expectancy, both for people with learning disability and for people with mental health problems. And we don't yet fully understand. We can see clearly some of the reasons for it, but we don't fully understand all of the reasons why this continues to be the case. And in order to achieve progress, being able to demonstrate to clinicians what actually happens in specific individual cases, I think is a good way of sort of challenging the system to demand improvements. But I think that, you know, we do have to try and instill a sort of sense that there is a moral imperative that we achieve this change. It is pretty hard to justify what's going on. And of course, you know, when I look at mental health and physical health, the crazy situation we have is that people with mental health problems don't get their physical health needs properly addressed.
That's right.
And people with physical health conditions, long-term conditions, don't have their mental health needs properly addressed. And it's in large part, I think it's a function of a very fragmented system which doesn't look at the whole person. That's why I am equally passionate about both making the case for improvements in mental health and indeed in learning disability, but also to argue the case for joining up care much more effectively.
And you've certainly spoken about trying to achieve parity of outcomes, which is, you know, the subtitle of our report, through perhaps integrating better integration of services. And there have been recommendations about different commissioning approaches, which I think NHS England is planning to do some work on. Could you say a bit more about how that would happen?
Well, yes. I mean, sometimes when people talk blithely about integration, they're thinking about health and social care. And that is a horrible divide which makes no sense. You know, if you were designing a system now, given the prevalence of people living with chronic conditions of a variety of sorts, often a mix of mental health and physical health, or a mix of learning disability with other conditions alongside it, to design a system as we have with health and social care institutionally divided and divided in terms of the funding makes no sense. But equally important in terms of joining up care around the needs of the individual is the physical mental health divide. We have to therefore improve the commissioning of care so that you don't commission little segments of a care pathway, you commission a whole package. I'm very interested in the moves towards this alliance contracting where you have a capitated budget, you might have a group of organisations that share risk and reward between them, moving fundamentally away from payment by results, which is simply incentivising activity in acute hospitals. It doesn't align with the objectives of what we're trying to achieve. And I want to see the emergence as a sort of evolution of, in effect, integrated care organisations at a local level. I want to, a permissive NHS which allows these things to develop so that you have some diversity across the system, and then you can start to test what works best and what delivers the best results for people.
So might this include, for example, the tariff for long-term conditions, or the tariff, take maternity, actually including mental health care within it, rather than commissioning mental health services separately?
Yeah,
would you see that as an example of integrated?
No, totally. And it's the sort of comorbidities that you come across. I mean, another example is between drug and alcohol misuse and mental health. Yep. We've managed to create a system where different organisations commission those services, local authorities for drug and alcohol and clinical commissioning groups for mental health. In my view, that makes no sense, and I think we've got to find a way of bringing it together. But if you know that a cohort of patients have a mix of mental health and physical health problems, and that one affects the other, then surely it makes sense to try and commission support for that individual, meeting all of their needs rather than doing it in a very siloed way.
I mean, I read the Achieving Better Access to Mental Health Services report with interest, but I was rather shocked that it didn't mention people with learning disabilities at all. And I mean, if you think about the mental health of people with learning disabilities who also have, for example, long-term conditions or a physical health problem, then you've got a kind of triple whammy, if you like. That seemed to be a missed opportunity. I
believe very strongly that everything we do needs to be focusing on ensuring equal access for everyone. And part of that is also, of course, about ensuring that the training of clinicians includes a recognition of this, because often it's sort of professional attitudes create in themselves quite a barrier to improving access.
We started talking about mental health literacy, and of course there is an issue about training of health professionals. What has been really heartening to see in recent weeks and months has been the growing mental health literacy amongst politicians, and that's been very comforting. And I think that often when leaders in the NHS perhaps don't speak out about mental health, or don't work themselves to reduce the gap between mental and physical health care, it's because they haven't got that literacy, because it's an area that is still unfamiliar to them. That is true amongst probably commissioners and amongst clinicians, and training is one way to reduce it. To reduce that sort of barrier, isn't it?
It's one way, but you can't put all your eggs in one basket. No. You need to confront every way in which the system denies fair treatment and fair outcomes. And my central sort of premise is that we have totally unacceptable discrimination at the heart of the NHS. So we have a whole set of access and waiting time standards in physical health, And I know from being in this building in the Department of Health that there is an enormous focus. Once you set standards, waiting time standards, so the 18-week referral to treatment target, the 2-week maximum wait to get referred to a specialist if you have suspected cancer, the 1 month to start your treatment from diagnosis if you have cancer, the 4-hour A&E target, it's endless. But once you set these standards, the system works to make certain, if it's possible, to achieve those targets.
But how to achieve them for people with mental illness?
No, the point I'm making is that that drives where the money goes.
Yeah.
And you have all of these standards in physical health. You have nothing, literally nothing, in mental health. And it's as sure as night follows day that mental health will lose out. And so the question I ask is, how can it possibly be acceptable that someone with suspected cancer gets a right to an appointment with a specialist within 2 weeks? Someone with a first episode of psychosis has no right at all. They may get access, they may not. That is intolerable,
I agree.
And it's utter discrimination. And that's why I've worked so hard to secure the introduction of access and waiting time standards, because I think it's fundamental to equal treatment, but not only to start introducing standards from next April, but to have a vision of how that's implemented over the next 5 years comprehensively across mental health. And because it forces the system, including commissioners, to think we've got to treat these two sides of the hitherto divide equally, because these people have rights as well as these other people. That at the moment is not the case. That's the scandal.
There's another scandal embedded within it, which is then you get another vulnerable group, like people with learning disabilities. There are others who don't get, the access for cancer treatment or the access for schizophrenia, because they are not seen as somehow eligible in quite the same way.
And they don't have a voice, and they are treated as second-class citizens.
Right. And the same is true for access to mental health care, where access, for example, to psychological therapies is currently not available. It's not offered.
Well, I understand about 1% of people who've gone through IAPT, increasing access to psychological therapies, are people with learning disability. But the bottom line is that not enough people with learning disability get access to those services, which may make a big impact on their lives and their quality of life. Right. But this is a situation where theoretically they have the right, but local services are denying them that right because ultimately they're treated as not quite as important as others. That's the sort of stigma. Cultural challenge.
And can you say a bit about what the government is doing to try and reduce stigma? I mean, you might want to talk a bit about Time to Change and how that's...
Well, I think Time to Change has been a really exciting campaign. We've financially supported it together with Comic Relief. I've just announced last Friday on World Mental Health Day that we would continue funding next year. But the fascinating thing is that it is working. The data, the evidence is showing changing attitudes. A long way to go still, but attitudes are changing. And I think scandals like Winterbourne View sort of force people to think, perhaps for the first time, this isn't tolerable. But what I found in the aftermath of Winterbourne View, the difficulty of changing culture and changing the way institutions behave is much more difficult than I had hoped. I found this the most depressing part of my job. Organisations signing up to an agreement to change practice, to get people out of institutions and then carrying on as business as usual. And that really is intolerable. So, you know, the frustration is I don't have the levers to force change. I have to encourage, to cajole, to push. We have to constantly be thinking, what more could we be doing to force the system to change? Is it about money flows, getting money out of these institutions? Should the state, where they run institutions in mental health trusts, in other words, state-run assessment and treatment centres, should we be thinking about trying to persuade those organisations to close some of them down? Something has to change, but it's extraordinarily difficult to change behaviour.
I'd agree with that. We know that £1 invested in liaison psychiatry services delivers savings of £2.50 to £3. That's one of the pieces of research that has been done. And that would include, for example, by reducing admission for people with moderate to severe depression who have long-term health conditions. We know that treating depression, for example, for somebody who's had a stroke in hospital speeds up their discharge and their rehabilitation. So it's kind of really, really important. Should the government think about commissioning someone like the King's Fund to consider how parity could be achieved from a quantitative point of view? You know, how much money would need to be put into mental health services in order to achieve the kind of outcomes that you really want to achieve?
Well, I'm always open to looking at what more we need to learn and understand. But just to pick up on your point about liaison psychiatry, part of the £120 million that the Deputy Prime Minister announced for this year and next for mental health is going into liaison psychiatry. We know the evidence is there. We know you get a return on your investment. We know that more important, it improves someone's care and their outcomes in the middle of a crisis. So why are we doing it? The RAID model from Birmingham has been well embedded there. I've been to visit it. So, you know, the objective is, and indeed also the government's doing with the winter pressures money, I got it sort of built into the rules of that, of accessing that money, that a local area must sign up to the Crisis Care Concordat and must look at introducing, if it's not already there, liaison psychiatry. So we're using every lever we can to try and get the system to change the way it behaves. And there is now a growing sort of base of good practice, but there's still a long way to go.
Do you think liaison psychiatry should be employed by acute trusts rather than
but it's just another demonstration of this ridiculous institutional fragmentation of the system. The fact that we have to have liaison psychiatry in a way makes the point that the system isn't well enough joined up.
Yeah,
because
exactly.
really they ought to be, it ought to just be part of the service that's provided. You also made the point about people with long-term physical health conditions getting access to psychological therapies. So I was fascinated to meet Andre Tiley, who is introducing the IAPT programme to people with heart conditions and delivering better outcomes for their physical health. Now this is the sort of innovative work that is quite exciting because you can see the impact that it's having.
I mean, it feels to me like this is a kind of a moment in history, really, where there's such a growing awareness of the importance of mental health, the extraordinary cost to our society, both in human terms but also financially, of mental illness, which remains untreated and then has lasting consequences for people's physical health. One of my colleagues at the BMA talked about a patient of his who died in her early 40s of lung cancer because it hadn't been seen as important enough, perhaps, in her earlier treatment to give her smoking cessation help. And yet smoking was something which it killed her. It was also something which comforted her during times when you know, there were just so many things that weren't working for her, you know, being out of work, being isolated, not getting access to quick and speedy treatment, and being forgotten when it came to public health interventions as well.
Yeah, well, I think, I think the announcement of the introduction of access and waiting time standards was, as a senior person from the mental health world said to me last week, a watershed moment.
Yes, I think so.
A big moment when suddenly the political classes wake up and recognise the ridiculous failure of the system to give our population what they are entitled to.
Yes.
And this long overdue recognition that your mental health, or indeed the fact that someone has a learning disability, should not in any way disadvantage them in terms of access to services. And it is for me a moral imperative that we change the way the system works.
We mustn't miss this opportunity and
no, we mustn't.
And allow mental health to
slip away again. Yeah.
And I for one really appreciate, I know the BMA does, your commitment to doing this. I think it's fantastic that the BMA is now made parity of outcomes, achieving parity of outcomes, part of its own policy.
Well, I applaud the BMA for doing that. I really do, because it's critical that the BMA shows leadership on this, and your work is incredibly important in this regard. From my point of view, this is a sort of personal mission. It's so important. There are lots of obstacles every day in the way of achieving progress, but it has to happen.
Well, I think you understand this, and just hope that many more politicians and leaders in the NHS will understand it too, which is that people are whole people. They aren't. Some people have mental illness, some people have physical illness. It's actually just not like that.
Yeah.
That one's physical health affects one's mental health and vice versa.
Absolutely. It's sort of blindingly obvious,
yes,
but we've missed it until now.
I know.
Yeah.
Well, thank you so much for talking to me. Brilliant.